I hope my presentation is visible, sir.
Yeah, it is visible.
So very good evening to everyone, and we bring this presentation to you from Department of Ophthalmology, Command Hospital, Chandigarh. I'll be discussing today about retinal detachment in cases of retinal vasculitis. So what we do in armed forces here is almost the standard protocol which is followed everywhere. That if you have a unilateral, non-vision threatening kind of retinal vasculitis, we prefer nowadays to give ocular and intraocular steroids. While if we have a condition of vision-threatening uveitis, we prefer systemic steroids or systemic disease-modifying anti-rheumatic drugs like methotrexate and azathioprine. CNP areas are lasered provided there is no macular retinal detachment. In these cases, we intervene early. And we believe in giving preoperative anti-VEGF in these cases before we enter. Most importantly, when we do these RD surgeries, as these patients are younger, we try to keep them phakic. If there is any evidence of neovascularization at this, we try not to do the PVT. And our belief in general is that a relief of fraction over the retinal detachment usually suffices, and to settle the retina on table itself is not necessary. For ILM peel, there is a difference of opinion between different armed forces surgeons, but I prefer to do ILM peel in most of my cases. And whenever we have a break or active disease, I prefer putting oil as Fentanyl. And most importantly, and this is the key issue, that not to give any harm to the patient. So managing glaucoma in these patients and to keep an eye on the endocrine disorders which may occur because of our treatment, especially systemic steroid, is extremely important. So what is armed forces perspective on this? Since we have a younger population and it's a mobile population, as you see that we move along all the borders of the country, we are exposed to much more antigenic variation, and hence the disease that occur in our population are more varied compared to general population. Macular involvement as well as bilateral disease are seen quite commonly. We have an advantage of having multi-speciality care under one roof, and hence we are able to diagnose these cases as systemic diseases more frequently and also treat these patients with non-steroidal agents much more frequently. Access to care becomes a problem sometimes when our patients are deployed in field and far-flung areas, and we have a major problem with residual disability because the patient loses his employment and army loses a trained manpower. So starting off with a case we see quite commonly, a young male presents with diminution of vision. We can see that his vision has dropped to 636 because of macular involvement in the right eye. A very large part of the eye is involved along with the disc. And his initial etiological investigations for tuberculosis as well as viral markers came out to be negative. We started the patient on oral steroids, and as a part of our protocol, we did CCT chest. Here I like to mention that though in previous books, mostly HRCT chest was prescribed as the investigation of choice, most radiologists now agree that it is CCT chest which is more beneficial in picking up either tuberculosis or sarcoidosis, which usually is the culprit in retinal vasculitis. So in this case also, we picked up a subclavian vein thrombosis. Our rheumatologist was available at hand. He suggested a HLA-B51 test, came positive, and we started treating this patient as patients. Why I present this case is that after 2 weeks of being on treatment as high as 2 milligram per kg of prednisolone, the patient kept complaining of reducing contrast in his left eye. So we repeated the fluorescein angiography this time, and we realized that the left eye now had active disease. And to add to our troubles, this patient started showing psychiatric symptoms to the oral steroids he was having, even to the extent of presuming deliberate self-harm. So we weighed our options and we tried something very different. IV cyclophosphamide, 750 milligram dose for 3 cycles, along with azathioprine at 150 milligram per day. This patient responded very well, even without any steroids. So my purpose of bringing up this case was that not all vasculitis are idiopathic or tubercular, and with increase in availability of investigations, we have to go a step further. We should challenge ourselves. Optic disc may be involved quite commonly in vasculitis, and we have to wait and look for symptoms like reduction in contrast and color, especially in the unaffected eye. The immune suppression has to be titrated with science, and we should not go by arbitrary limits like 1 milligram per kg or 2 milligram per kg. We should see that what is the disease activity clinically and on imaging, and then we should titrate our drugs. And there is no harm in using steroid-sparing agents, not only for chronic rescue like methotrexate or azathioprine, but also for acute cases where we can use IV cyclophosphamide, rituximab, or adalimumab. So coming to retinal detachment and retinal vasculitis, we all believe that yes, peripheral retina is the one which is usually affected, but we must pay attention to the macular disease because macular disease may require treatment if there is an epiretinal membrane or cystoid macular edema present. There is a huge variation based on etiology, and earlier a large subset which was dumped as idiopathic or EELS is now shrinking because people are investigating these patients better and taking consultation of their immunology and rheumatology colleagues. These patients require a very long-term disease management because the course of disease may last from anything from 2 years to up to 10 years. Biologicals and steroid-sparing agents both will require observation by other specialities. And since these patients have younger age, the disease effect lasts for a longer time. They are a sort of burden both to the organization that is army, to themselves and to the country. So we have to address their disease early and fast. And surgically, PVD is difficult, and PVR, God forbid it occurs, is very worse to handle. We have a slightly different view compared to what I have seen in RPC and my colleagues have seen in other centers of excellence. That we observe these periods for very long duration at multiple centers. They have something called system of repeated opinions every 2 years. So you keep seeing their notes over past 5, 10, 15, and sometimes 20 years. The systemic disease manifests over a period of time, and it is easy to pick up diagnoses like Behçet's, diagnoses like VKH, and there is an emphasis on systemic diagnosis because we want to ascertain the employability of these patients. For example, the case in point I presented, he already had a thrombosis in normal ground condition. If such patients are deployed in high altitude area, they'll be at risk both to themselves and to others because they may develop cerebral venous thrombosis also. And we prefer robust treatments. We don't like oral steroid for a long time because they do not leave a person fit for employment. If you use a short span of DMARDs, at least after 6 to 12 months or 18 months, whenever they are over, the person is fit enough to continue service. And we prefer oil over gas in cases where we are not able to observe them. Preoperative considerations include the role of ultrasound. There is a role of OCT macula, especially if the macula is involved early, even before you operate, you can tell the patient about the poor prognosis. Intravitreal anti-VEGF has been described by none other than Professor Atul way back in 2012 when he said that it should not be delayed by more than 7 days once we inject the patient with anti-VEGF because then it may be counterproductive and actually lead to formation of a regma. Ideally, we give anti-VEGF 3 days prior to surgery, and we are using IVMP regularly, IV cyclophosphamide, intravitreal methotrexate, and biologicals. OCT has come up recently, and this kind of image, once you see, this is from the same patient, tells you that the disease is very severe, and even if you treat this patient very well, the loss of field and vision will be quite significant. In the operative consideration, we try to keep the patient phakic. As Professor Atul mentioned, smaller gauge is preferable because with a 27 gauge cutter, it acts both like a cutter and suction device as well as a scissor. On table, you have to assess for regma. PVD management is quite difficult in these patients. You have to identify the planes correctly. I'll be showing them in my videos. So in this particular video, on the left-hand side, you can see that when we were trying to do the vitrectomy, you were not able to see the periphery of the retina because of this small blob of blood. And it is possible to go behind the lens and eat away all this vitreous hemorrhage which is sticking to the posterior surface of the lens. The actual nature of the RD you will come to know only when you clear the vitreous hemorrhage. As in both these cases, we realized that we were not dealing only with fractional but regmatogenous elements. And then Intraoperatively, you sometimes have to change your management with use of external buckles. EVD is usually done when disc is not involved with NVD, and we try to keep it in a direction away from TRD. Like now you see I'm moving inferiorly, but I will stop just before I reach the place where the traction is present so that you don't create an additional break. The cautery has to be very careful before you start cutting the bands, and as you can see, with careful use of cautery and cutter of small gauge, you are able to get away with most of the traction. Similarly, the vitreous hemorrhage should be removed up to the base because I believe that sometimes we leave certain breaks in the periphery, and after 6 to 7 weeks, patient turn up with a retinal detachment. So it is a good idea to have a look at a clean shaven base all over. I do ILM peel with a mindset that most of these are inflammatory condition and will later on lead to a secondary epiretinal membrane or cystoid macular edema. Both of them do very well once an ILM peel has been done. The retinotomies have to be assessed on table, try to do laser till ora, tolerate a little bit of residual retinal memory. I'll show you one of the examples. So on the left hand side, we can see a video of an ILM peel. Though I have stained in this particular case, in most of my cases, I have an advantage of the residual blood lying over the macula with the retina thrown into the folds. And even without staining with BBG dye, sometimes you can peel quite comfortably. I try to peel from between the arcades to release the traction. And the hemorrhage, as you can see on the right hand side video, I will try to clear it up to the ora to have a clear view of not having caused an iatrogenic break on table, which is very much possible in a thick vitreous hemorrhage. And always try to do your cautery under air and titrate it. And the cautery instrument can also be used to extend your retinotomies without having to change instruments. And after completion of the relaxing retinotomy, this is a case of TRD which detached again. And after that, I had to do Revia. And once you have done such a large retinotomy, it's a good idea to put oil. Now coming to one of the examples where he did well. So there was a localized retinal tinting with two breaks, as you can see inferiorly in this area. And both these breaks, I left them under oil. My laser did not come right at the edges of the break, but around it. And we waited without entering again. And right after 3 months, you can see that the retina settled because all the surface traction was removed. So even if you have a reg bump with most of the surface traction removed, it works. And to compare with that, this is another case where you can see preoperatively on the left-hand side, there was a traction, and this traction led to a small oval break outside the arcade. What went wrong was that this patient had a wedding at his house and allowed him to go for this wedding presented after 6 weeks. And when I tried to operate him, this is what happened, that the patient was left behind with a large amount of residual surface traction. And sometimes you don't do well with such cases. And the surgery itself may be more damaging than what the patient started off with. So surgery in retinal vasculitis-induced retinal detachment is a very tricky disease. And lastly, do not wait for large TRDs to resolve spontaneously. When we started learning ophthalmology way back in 2008, there was the concept that if it's a TRD, you should wait. But if you wait for too long, this is what happens, and there is nothing which is recoverable after that. Thank you so much.